Hello, everyone, and welcome to a WEDI Virtual Spotlight, Axing the Fax, Industry Perspectives on the New Attachments Rule. It's my pleasure to introduce WEDI's Board Chair from Aetna, Mary Lee Stein.
Hello, everyone, and welcome to this exciting topic. I know that we've all been very excited about this new rule that we've been waiting for a very long time. Next slide. Um, Little information about WEDI, although I would wager that everyone on the phone is probably pretty familiar because as this was a session that was featured as free for our WEDI membership, and I believe that most everyone on the phone is WEDI members. You're familiar with the fact that we are named in the HIPAA regulation as an advisor to the Secretary of Health and Human Services, formed in 1991 by then Secretary Dr. Lewis Sullivan. Our mission is to provide multi-stakeholder leadership and guidance to the healthcare system on leveraging the industry's collective technology, knowledge, and expertise to improve the efficiency and quality of healthcare. And attachments is a very good way to do that. Next slide, please. How do we do that? How do we support Health IT as both a convener and an advisor? Our convener side is through our education guidance, which happens through our work groups. Our advisor role is, again, as an official advisor to Health and Human Services. We do that through member position advisory sessions and through comments and letters, which again, we use through our work groups. Today, we have multiple volunteer work groups, sub-work groups, and task groups that provide thoughtful leadership, common sense approaches, and enhance the exchange of clinical and administrative healthcare information. We collect input, we exchange ideas, make recommendations, and inspire impactful and far-reaching change in our industry. Visit our workgroup community homepage on wedi.org to learn more and sign up. Today's session will feature two of those sub-work groups, our claims and attachments sub-work groups. And at this point, I'd like to hand it over to Rob for some more information on today's session.
Thank you, Marilee, and thank you for your leadership of our organization. As Marilee said, we've got 17 work groups, sub-work groups, and task groups. Two of those are going to be featured here today. We have an attachment sub-work group, and you can see here the co-chairs are Marilyn Bushman, Rosemary Hodges, and Jamie Mostadler. And I think, we've been waiting a long time, as Marilee said. We're very excited by this rule, and I would encourage you to join the sub-work group. You can reach out to our own Ariana Poole. It meets every third Wednesday of the month from 3 to 4. And as you can imagine, it's going to be a platform for discussion of the rule and, of course, how to best implement it. Next slide. And they will be working in tandem with our claims sub work group as well. And that the leaders there are Beth Davis, Stanley Nachumson, and Chuck Viverka. They meet twice a month, the second and fourth Thursday of the month from 11 to 12. And again, if you're interested in these issues, the sub work groups are a perfect place to come and share ideas, to ask questions, and of course, learn from your colleagues. Next slide. I also wanted to let you all know of a brand new process that we have in place now. We've seen that there is a need in the industry to collect information from stakeholders ahead of potential rulemaking. So what we've created is the Federal Policy Consultation Process, or FPC, and it's really an opportunity to reach out to folks within WEDI and in the broader healthcare community to engage on key issues that could impact your organization. And the first one we're looking at is the new X12 version 8060 of the HIPAA transactions. We will be engaging with folks, and I'll explain how in a second, with the end goal being WEDI issuing a report to HHS on the perspectives shared with us by stakeholders. And to help that process along, we've developed what we call the WEDI HIPAA resource page. It's accessible from the Knowledge Center on our homepage, and it gives background on HIPAA, the supporting regulations. We've also got recorded sessions from our DC conference this past fall. And we also have links to X12 and their resources as well. We urge you to complete the survey. We worked closely with CMS and their contractors to develop what we think is a very concise but important survey to try to determine your perspectives on the potential benefits and costs associated with this new version of the transactions. We also encourage you to submit comments through our online portal. We have three basic questions. Again, the benefits and costs, any challenges, potential challenges associated with implementation, and then finally, a sort of a catch-all, anything that you wanted to share with WEDI and ultimately with HHS on issues around 8060. And then finally, we're going to hold a live event later this month on the 22nd. It'll be 4 hours. We'll have a number of panels representing health plans, providers, clearinghouses, others, giving their perspectives on version 8060. But also, we will have an open time. So if you wanted to come and share your organization's thoughts and recommendations, that is a perfect time. I just wanted to acknowledge this FPC process was developed through the WEDI Policy Committee, chaired by our own Pam Grosse. So thank you, Pam, and the members of the committee. Next slide. So very quickly, we're going to move into the introduction and overview of the final rule from CMS, and then we'll get into our stakeholder panel. I think we can skip ahead to the next slide. This is an interactive event. It's a unique opportunity for you to ask your questions or share your perspectives. We've got literally the top national experts on the attachments rule here with us today. So take advantage of that. And as always, we will share the slides and recordings with you after the event, so you can distribute them to your colleagues in your organization. And with that, I wanted to introduce both Michael and Janelle. Michael is director of the National Standards Group. He's acting director of the Health Informatics and Interoperability Group at the Office of Healthcare Experience and Interoperability, of course, at the Centers for Medicare and Medicaid Services. Janelle is technical advisor at CMS. And I know firsthand that they had a cake and ice cream to celebrate the release of the rule. And I can tell you many in the industry shared that cake and ice cream as well. So we're very excited about this new rule. And with that, I will turn it over to Michael and Janelle.
Yeah, thanks, Rob. I just want to thank WEDI for the opportunity to present to you all today and be part of the discussion. So Janelle's going to speak in more detail on the rule, but I just wanted to quickly highlight that I think most of you know this rule has been years in the making. And we, through that process, have meticulously reviewed all of the feedback that we've received from industry to develop the best combination of standards to support the transmission of healthcare claims attachments. And had to do so in a way that would make providers and payers want to move away from the use of those external delivery methods, such as fax and email, and really increase the adoption of the use of the electronic method. And of course, the overall goal always being to increase efficiency and get to a better patient care experience. So without further ado, I'll hand things over to Janelle. Thank you.
Thank you, Mike, and good afternoon, everyone. And thank you again, WEDI, for the invitation to be here with you today. As Rob and Michael both stated, I'm Janelle Herring, and I am a technical advisor within the National Standards Group in OHE. And I am also one of the authors of the Healthcare Claims Attachments Final Rule, one of 3 authors, so it's not just me. So today we're here to talk about a really important milestone in the healthcare administrative modernization, the final rule of the Healthcare Claims Attachments, Transactions, and Electronic Signature Standards. At a high level, this rule, we believe, is a big step forward. It's about reducing administrative burden and improving efficiency across the healthcare system. So what I'd like to do here today is walk you through what this rule means for HIPAA-covered entities and how it's going to change the way in which we exchange administrative and clinical documentation when adjudicating claims. So to understand how we got here, we need to look at 2 key laws, HIPAA, which was passed in 1996, and the Affordable Care Act from 2010. HIPAA was really groundbreaking for its time. It required standardized electronic transactions and pushed the industry away from paper-based processes. The goal was simple: improve efficiency, reduce costs, and cut down on administrative work. So back in 2005, and Stanley, I'm sure you remember this, HIPAA did propose standards for healthcare claims attachments, but the public comments we received at the time was clear. The technology was not ready. The industry wasn't prepared to implement electronic clinical data exchange at that point as well. So those standards were never finalized. So we fast forward to 2010 and the Affordable Care Act essentially reaffirmed that the requirement to adopt a healthcare claim standard needed to happen. So it told us not only to adopt a healthcare claims attachment standard, but it also said make sure that it aligned with version X12 version 5010. X12 version 5010. So taken together, these 2 laws set the foundation for continuous improvement in healthcare administration and this final rule, which is a next step in that evolution. So the current landscape is, let's talk about the problem that this final rule, we believe, was trying to solve. We heard from health plans who said they often needed additional information to make coverage determinations, but that information usually isn't captured in a standard claims or in authorization transactions. So a lot of data ends up to be transmitted in free text fields, or it was either sent through mail, fax, or phone calls. We heard consistently from our stakeholders that this lack of standardization and the lack of standardization in this electronic exchange of information was a major pain point. And that's exactly what this rule is designed to address. So what does this rule actually do? It does 3 big things. First, it adopts standards for sending healthcare claims attachments electronically, things like medical records, lab results, x-rays, and provider notes. Second, it establishes a requirement for electronic signatures so that these exchanges are secure and legally valid. And third, it does have a potential to save upwards of $781 million annually in administrative costs for HIPAA-covered entities. So for us, it's not just a statistic, it's money that can be put back into patient care, technology, and workforce support. So why now, you're asking? We've had a lot of people ask us, why did it take so long, 21 years to be exact? The short answer is the laws, the two that I mentioned, required that we adopted a healthcare claims transaction. But the bigger picture is that while healthcare has made huge strides, like adopting electronic health records, the process for sending attachments remained stuck, right? They still were doing manual processes, relying heavily on fax machines, mail, and we believe that that's an inefficient way, as well as an error-prone way to, attack healthcare. So this rule, we believe, closes that by standardizing how the administrative and clinical data is shared. And we believe the benefits are clear: better data exchange, less manual work, lower costs, and more time for providers to focus on patient care. I'd like to note one thing in particular. So while we talk about no faxes, we've received a lot of questions regarding this rule and whether or not fax machines are still able to be used in healthcare. And so it's important to note that this rule does not eliminate other methods like portals or faxes. It just simply applies to when the electronic standard is used. The way in which that it should be done is through electronic transmission. But if you have those alternative methods that continues to work with you and your health plan, this rule does not eliminate those methods. So again, how did we get here? So we did publish a proposed rule in December of 2022. And as Michael alluded to, we did receive a lot of feedback. And we thank you all for the feedback that you shared. We received so much feedback that we did extend the comment period beyond the 60 days for it to be in total a 90 public comment period. And that period extended through April of 2023. And for us, it was important to ensure that everyone had an opportunity to weigh in on this rule and to ensure that, whatever we moved to finalize did in fact meet the moment and again, eliminated the pain point that we've heard so much about. One of the key decisions that we made based on the feedback that we received through the public comment period was not to finalize standards for prior authorization attachments at this time. I just wanted to touch upon some of the comments that we heard, and we do discuss those comments and our responses to those comments in greater detail in the final rule. But just to flag, we received commenters stating to us that the limited experience with the X12278 transaction standard, as well as the variability in workflows and potential conflicts with newer interoperability efforts like FHIR-based APIs, caused a concern. And so we did not move forward with adopting the 278 standard within healthcare claims attachments, but just wanted to note that while we did not do that, we are continually evaluating those options and will monitor industry progress. Again, to look at, what we could do to ensure that we are continually staying abreast on new technologies and staying on top of how to minimize any burden that providers may face with multiple regulatory efforts and things like that. I also wanted to just quickly touch upon the compliance dates and the dates that are in the regulation. We did find out that in earlier communications, there were some concerns or conflicts with the dates. And so just wanting to flag that the final rule was published on March 26th of 2026. And so our effective dates are always 60 days later from the publication date. So that makes the effective date of this final rule May 26th of 2026. And with the statute and ACA only giving us the authority to have a 24-month compliance date, that then puts the compliance date 2 years after May 26th of 2026. So therefore, the compliance date is May 26th of 2028. And we hope that that is well enough, more than enough time for covered entities to be in compliance. But if there is any questions regarding that, please do not hesitate to share your feedback with us through our administrative simplification mailbox. And so now I will walk through those key components within the final rule. In the proposed rule, we had proposed a definition of attachments information, and we felt that was important to sort of define all of the information that would be enveloped into a claim. And so we did not change that definition. And so it continues to read that attachment information is defined as the documentation that it enables the health plan to make a decision about healthcare that's not included in the healthcare claims or equivalent information transaction. And how we arrived at that definition is based on some of the key aspects from the 2016 NCVHS recommendation, where it was discussed that a definition of attachment information should be included in our attempt to adopt a healthcare attachment standard, and that the definition should be broad and general enough to include all possible patient-related information that could be generated with a response to healthcare services. And so again, we believe that our finalization of the definition that we propose does that. We did receive some comments expressing concern that too broad of a definition could allow health plans or payers to require supplemental documentation for routine care. And, you know, while we appreciate all concerns that we received and that were raised in this final rule, we did not believe that it was appropriate or necessary to modify the definition that we finalized to account for such concerns, and that we believe that we were clear in that the information required would be those needed to, you know, adjudicate a claim. However, it's important for us to also note that a health plan's business or payment decision rules do fall outside of HIPAA. And so whatever those rules are, you know, covered entities need to continue to follow those regarding that business arrangement. We also adopted a definition of healthcare claims attachments transaction. And so we did not change the definition and how it read from the proposed rule to the final rule. And so that definition continues to read that it's defined as the transmission of attachment information from a healthcare provider to a health plan in support of healthcare claims or equivalent encounter information transaction, or a request from a health plan to a healthcare provider for its attachment information. Again, during the comment period, we did receive some, you know, comments regarding that definition, and the concern primarily was centered around the idea that the definition being too broad could capture all possible patient-related health services information. And as I'm saying to you today, as well as what we said in the final rule, we emphasize that the HIPAA transaction standards govern the format and the conduct of the electronic transactions. Determinations about the amount or the type of documentation that a health plan may request in support of adjudicating a claim remain subject to the health plan's business rules, as well as any governing laws. And so at 162-103, the definition for attachment information, and we do, in fact, encourage you to read the final rule. And if there continues to be any questions or concerns regarding that, we definitely want to hear from you. Finally, on that note, I'll just say or reiterate that this rule, we believe, does not create any new requirements for HIPAA-covered entities that do not originate or maintain the documentation that's needed to adjudicate a healthcare claims transaction or a healthcare claim. The standard only applies to the exchange of the documentation within those transaction standards that we adopted. And I say that because we did, in fact, receive some concerns or questions prior to our town hall regarding some of the post-payment audit programs that some of the health plans undertake. And for example, they talked about the CMS review programs, such as the Review Choice Determination, RCD, Targeted Probe and Educate, which is TPE, and any other medical review activities that we weren't made aware of, but it applies to all of them. And what we've said to the person that asked the question, as well as President Hall, and I'm doing here so today, is that medical review activities are not automatically required to adopt the standards that we adopted unless and until those programs are explicitly updated to use the HIPAA transactions. So many of those post audit programs, they rely on separate submission processes, such as portals and faxes and other things. And so this rule does not mandate an immediate conversion to the standards that we adopted in order to do those programs. So I thought it was important to, share that information here as well. So the standards that we adopted are twofold. One, we adopted the X12 standards as well as the HL7 CCDA. More specifically, we adopted the X12 275 version 6020, which is the additional information to support a healthcare claim or encounter, and that's used for sending the attachment information. And then we also adopted the X12 version 6020-277, which is the healthcare claim request for additional services transaction. And that's used for requesting additional information or providing claim status updates. And these two standards, these two X12 standards, they act as the envelope for the data and clinical information that's being exchanged. We also adopted 3 HL7 HL7 implementation guides to use with the healthcare claims attachments standards. One is the HL7 CCDA IG Volume 1, the HL7 CCDA IG Volume 2, and the HL7 IG. These standards that we finalize within this rule for the use of healthcare claims attachment standards apply to both solicited attachments, and so that's when a healthcare provider transmits additional information in response to a health plan's specific electronic request, as well as unsolicited, and that's when a provider includes attachments with an initial claim submission based on a pre-established health plan, requirements without an explicit request from the health plan. We received numerous comments on our proposals that they demonstrated a 2016 based thinking by proposing the use of the X12 standards, which, they stated would make the evolution of the processes for requesting and responding to supplemental data needs more difficult and burdensome. And, other commenters went on to, highlight some of the newer technologies like FHIR and the like. So what we said in our final rule, and I'll say here today, is we chose the X12 standards because twofold. One, we interpreted the Section 1104 of the ACA, where it said we needed to adopt a healthcare claims attachment transaction standard that would be consistent with X12 version 5010. And so we stayed in line with that, and so we adopted 6020. Which was the newer version for the 275 and the 277. But we also believe that those X12 transaction standards are widely implemented, and they provide a stable, reliable path forward for us adopting a healthcare claims attachment standard initially, for at least for now. And so one of the things I wanted to flag that we continue to look at all of the new technologies and evaluate all of the feedback that we receive from stakeholders such as WEDI and the like. And, we'll consider those. And if there's a need for us to move forward with future rulemaking, we are definitely positioned to do so. And so we hope that what we shared in the final rule and what I'm sharing here today, signals our commitment in doing so. And then with regards to electronic signatures, which was another major piece of this final rule, we adopted the HL7IG for CDA Release 2 Digital Signatures and Delegation of Rights Guide. And we believe that this standard will ensure that the attachments being sent is secure and trustworthy. Some of the key things that this standard will do is verify who signed the document, ensure that the content has not been altered, as well as it prevents the signer from denying their involvement with the transaction. One of the things I wanted to clarify with regards to this electronic signature standard, it doesn't alter any previous regulations regarding how a provider or a person would apply the electronic signature standard to like general medical records or claim order forms or any enrollment forms. Those are governed by other rules. The use of this standard for digital signatures is only when doing the electronic healthcare claims attachments transaction. So I'll close with a couple of final thoughts, and I'm sure that you all probably have some really good questions, and so we'll get to that and looking forward to it. That at the end of the day, this rule is about modernization. It's about moving from outdated manual processes towards a more efficient and standardized way of exchanging information. And we hope that once implemented, it will reduce any burden, definitely lower costs, and more importantly, free up time and resources that, HIPAA-covered entities can spend on patient care. And if you haven't already, please, view the final rule in the Federal Register and on the CMS website, particularly the Admin Cent webpage. We do have our press release, FAQs, as well as the fact sheet that we hope you are able to use in support of implementing this transaction standard. And again, if there's any questions, please feel free to send us an email. We'd be more than happy to address your questions or concerns. And that, I'll turn it back over to you, Michael. Thank you.
Excellent. Thank you, Janelle. We do have a couple of questions in the chat if you do have a minute or two. The rest of them will still stay in the chat. I have one here. Are providers only allowed to submit an unsolicited attachment when it is included in the electronic claim?
I'm sorry, Michael. I had a hard time hearing you.
Oh, I'm sorry. Let me try to
No
speak up
problem.
though. Are providers only allowed to submit an unsolicited attachment when it is included with the electronic claim?
Are providers only, I'm not sure. Is there, whoever asked the question, can you sort of give an example? Certain.
We'll wait for that, but we do have what I would suggest is as we continue with our panel, the chat actually has all the questions there. So
Okay.
feel free to review the chat and you can reply to the folks there. Feel free not to reply directly as a direct message so
Got
everyone
it.
can see the answers.
Thank you.
All right. I'd like to hand it right back off to our Executive Director, Robert Tennant, who will introduce our panel.
Wonderful. Yeah. Thank you, Janelle. That was an excellent overview. There's as you can imagine, as we do a deep dive into the rule, there's going to be a lot of questions about how this will apply logistically and in the real world of healthcare. And to help us walk through that, we've got really excellent experts to help us. As I mentioned, we've got Marilyn Bushman from WellPoint Federal, Jamie Mostadler from Japari, Beth Davis from Veradigm, Chuck Faverka from Kunsley and Associates, and Stanley Nachemson from Nachemson Advisors. And the moderator will be Pam, and I will turn it over to you to start the discussion.
Great. Thanks, Rob. Well, welcome everyone, and welcome to our panelists. Thank you for participating today and sharing your expertise. We'll kick it right off here. The first question, it's been approximately 30 years since HIPAA passed and attachments was named as a standard. So what does having a final rule finally mean to the industry? And then I'll start with you. All right, I'll jump to Stanley since Mary Lynn is having some trouble unmuting. So Stanley, would you mind jumping in on that one?
Not at all. Very pleased to see this final rule, and I think what it does is to remove the exclusive obstacles that providers and health plans and vendors have had for not implementing electronic transactions. Although in the pilot tests and some of the work that's already been done, we've shown return on investment. Folks have said, well, there's no HIPAA requirement, so I'm not going to invest my time or energy in creating products or moving towards electronic transactions. That's because it's no longer true. We would expect the industry to enthusiastically embrace these standards and move forward and take advantage of them as much as they've taken advantage of electronic claims and remittance advices and such.
Thanks. And Mary Lynn, are you able to unmute now?
I am able to unmute. Sorry about that. I got kicked off and Michael had to re-unmute me. So yeah, definitely agree with everything Stanley said. I think this is great for the industry. As you know, we at WellPoint Federal, formerly known as NGS, we've implemented the 275 and HL7 standards for electronic attachments. We've had it in production for over 12 years now, and we've seen the value, right? We've seen all the benefits, and so have all of our providers. So thanks, Pam. I think Jamie might have some comments as well.
Great, Jamie.
Yeah, it's going to be very helpful to have some standards put out there, like not understating it, but having some consistency with the mandated versions. Today, we have people using 5010, 6020, all different flavors of the claim, the attachment, the RFI. So having some consistency is going to be really beneficial and simplification for all the players involved.
Thanks. And Mary Lynn, you started kind of leading into this question. The final rule adopts 6020, 275, and the 277 RFAI. The claim is currently on version 5010, and X12 has recommended adoption of version 8060 of the entire suite of HIPAA standards. So how do you see these versions all coming together? Mary Lynn?
Thanks, Pam. Appreciate that question. So as I said, we've been in production for over 12 years now. So of course, we're only receiving the 5010 claim, and we implemented the 6020 version of the 275. So that is the version that was named in the regulation. And we've had no problems at all with the two different versions. Everything works fine. They're, of course, in different interchanges when they're sent into us when we receive them, but no problems with processing the claim and then processing the matching attachment with that claim. So we are expecting the same thing with 8060. We're not expecting any issues at all. If the claim does move to version 8060 for the X12 formats with the 6020 275, we don't see that as an issue at all.
Great. Jamie, I don't know if you have any comments on that one.
I did not. I think Beth might have had something.
Great, Beth.
Well, I was just commenting on there was a question about whether the attachment could be sent without the claim. And I was just responding there that, I've never been asked that question before, but I didn't see really a path for sending an attachment without a claim because of what I know goes on the back end to reconcile the two together. They're very symbiotic. The way they work together. And I don't know that I don't think it supports sending an attachment without a claim through this process, though a payer could implement their own process for attachments alone. So, yeah, thanks.
Great, thanks. And Chuck?
Yeah, that would be an interesting question. I'm sorry, Pam.
Go ahead.
Could Mary Lynn address that? Has Mary Lynn ever faced that situation where providers have sent in attachments after they've submitted a claim before the health plan asks for it?
Yes, we support both the unsolicited as well as the solicited. So when they're sending it in unsolicited, we have some business rules around that, right? They have to send the claim first, and then we must receive the attachment data within 7 days. Otherwise, it'll continue through the processing, our normal processing approach. So we do need the claim, though. If it's attachment information and it's supporting information to a claim. So we definitely would need a claim in order to do anything with that attachment documentation. Otherwise, we don't know what to do with it if it doesn't match to a claim. Same thing with solicited, right? The provider's already sent the claim in to us. And we realize we need additional information to process that claim. So we will ask the provider for that additional documentation. For example, maybe op notes or something. So then we'll request that information using the X12 277 request for additional information, and the provider will respond with the 275, but it still matches that original claim.
Yeah, and from the
I think it's
clearinghouse
important.
perspective, I think we've found great success with the unsolicited model. It's less interruptive in some of the provider workflow where they're not used to getting the RFAI 277 as far as to trigger to send the attachment. They can set up their system to send the attachment in parallel or shortly after the claim without waiting for a request because they know it's going to need one. So the unsolicited is very popular and very successful today.
All right. So this is the first time that we're seeing the combination of X12 and HL7 standards to transport data, with the X12 transaction being the envelope and the HL7 standard conveying the payload or the actual attachment. What are your thoughts on this approach? And I'll start with Chuck, since you haven't had the opportunity to speak yet.
Thank you. First of all, both X12 and HL7 provide the industry and all of us with a standard. So when we turn to our software developers, I'm sure they're going to be able to produce a very compliant solution that incorporates both. Solution might not be optimal in all instances for all entities in the healthcare industry, but finally having these as standards is the key point. Our focus should be on getting the attachment solution in place. So we all need to get this implementation on our planning schedules, on our roadmaps, if it isn't already there. The rule is calling out for a 2-year implementation horizon. 2 years is going to pass by very quickly. And because we all have many other resource issues and initiatives to support, it's much better to get this work established as a project now so we can actually reach the endpoint so that we can start benefiting from the benefits that, for example, have been identified by CQH Core.
Thanks. Stanley, any additional comments there?
Oh, yeah, a couple of things. Both X12 and HL7 and some of the work groups that I've sat in on have said that they will be producing information, some guidance on the use of both of their standards in the attachment. So look for that and download, for those that are members, download the appropriate information or look to those sources for getting that information and how it works. So I think we'll be benefiting from that. Also wanted to point out that although the reg sets a 2028 implementation date by which everyone must be complying with the standards, anyone can start implementing those at any time as of today if you're ready, and much as Mary Lynn has been and her company have been using these transactions. You can implement them at any time up until 2028. So don't necessarily set 2028 as the implementation date. If you can get it together and are ready to do it ahead of time, please go ahead and implement that.
Pam, if I could, I was just going to mention in the chat, and related to this, there was a question about whether providers are not required to use this, even though certain payers and intermediaries are required to provide this technology. There's a caveat to that with providers that that there is a MIPS requirement that that they need to send, I believe, at least one, or actually, I'll take that back. I'm conflating that with prior authorization, which is also attachment based. So please strike that. Both of them start running together in my mind.
There is a lot. You're right. That requirement you're talking about is prior auth. But
and Pam, I'd just like to add to it. So I know many years ago, in the beginning, a lot of the industry were very concerned about two standards in one transaction, right? How's that going to work? Because we don't have anything else like that. But when we implemented it, we require HL7 in that binary or the BDS segment of the 275. And we've had no problems at all with processing that transaction with two standards in it. So I just want to make sure everybody understood that. So we have the X12 275 as the wrapper, and in that binary or BDS segment is the HL7 consolidated CDA release 2. Release 2.1, sorry about that.
And Jamie, do you have any comments on that question? How the two standards work together?
Nothing to add that hasn't been said already.
Great, thank you. Well, Mary Lynn, as we've already mentioned, WellPoint has already implemented the transactions that we're talking about here. What are the key lessons learned that you could share with the audience?
Sure. I've got a couple that I can share with you. The first one is, as Jamie said, with unsolicited. We have found a lot of success with the unsolicited model. Providers would rather send in the documentation with the claim or around the same time as the claim, right? Rather than waiting for us as a payer to request that information. They're getting paid faster if they send it in with the claim. We did implement the solicited model as well. But we only have a few providers who've enrolled for that. So we don't see that very often. As with the unsolicited model, we have close to 3,000 providers sending thousands of 275s every month. So that definitely was a lessons learned for us. Another one was we learned that there was definitely a learning curve with HL7. Even though we had been involved in the HL7 work groups and going to the conferences and everything, when you go to implement a standard, you always have to look at it a little bit different than when you're sitting in a room talking about it, discussing issues and things like that. So there definitely was a learning curve. We made it through all of it. We had to reach out to some HL7 folks that really helped us. So that was great. So I would say the lessons learned out of that is we've got to make sure there's a lot of education, especially around the HL7 piece. We also, oh, go ahead.
Sorry. I just wanted to follow up on one of your first comments, and I didn't mean to interrupt you. Sorry. You mentioned doing an enrollment for the solicited 275. Do you require enrollments for that? And do you also require enrollments to send an unsolicited?
Yes, we're a Medicare fee-for-service contractor. So, of course, we've got to follow the CMS guidelines, and we are required to enroll our providers for any new transaction. So, yes, enrollment is required for us for both of those.
Great. And I just want to call that out because I think that's a really important note and something that needs to be considered as part of people's implementation timelines.
So
exactly.
I'll just add to that there's lots of other payers that don't require re-enrollment, don't require enrollment for attachments. So I mean, just balance that. It's just dependent on the payer.
And then I'm sorry, Mary Lynn, I interrupted what you were saying. So please continue.
That's okay. I have a couple more if you want me to keep going.
Yes, keep going.
All right. So another one is, as you know, HL7 uses the LOINC codes. And we did find in our implementation that there were some LOINC codes that we needed for electronic attachments. However, they were in the RELMA database, which is a database that holds all the LOINC codes. However, they were not noted as an attachment LOINC code. So we worked through the HL7 attachment work group, and we did get them added to, as an attachment LOIN code in the RELMA database. And there is information about that, I believe, in the HL7 implementation guide that was named in the regulation. I think there's a section on how the industry needs to handle that, and go to the HL7 work group for that information. So that was a lessons learned as well. And then the last one that I have is for the solicited model. It was a bit of a challenge, but we were able to complete it. We needed to map the data out of our shared system. So again, the claim was submitted from the provider. We wanted to request that information. Typically, our current process is mainly paper. So a paper letter is created to send out to the providers requesting the information. So we needed to map all the data in that paper letter to the X12 277 transaction. So there was a lot of learned lessons from that on where to map that data. What did we do if we didn't have the data we needed? Things like that. We did ultimately get it completed, and we were able to map all the data that was required in the X12 277 transaction.
And we do have a follow-up question around the enrollments from the chat. Does the provider have to choose solicited versus unsolicited model globally when they enroll for all claims, or do they have to enroll separately to send unsolicited versus solicited?
We would allow them to enroll for both. They're separate transactions. So of course they have to enroll for the 275 and enroll for the 277 request for additional information. But they can do it with one enrollment.
Okay, great. All right, well, moving on, Jamie, next question is for you. You have experience using the 275 from the clearinghouse perspective. So what lessons learned can you share?
Yeah, I touched on some of them earlier, but at Japari, we started working with the 275 and attachments all the way back in 2009 in the workers' comp space. So it's something we've been doing for quite a while. One of the things was needing to provide flexible integration solutions based upon the stakeholder, both provider and payer's readiness from low tech to high tech. So we really needed to be flexible with both sides of the transaction. And again, we had started with the solicited flow, but didn't have great adoption. Again, as I mentioned earlier, the provider workflow, they know when they need an attachment, and the unsolicited just in many cases works a lot better for them as opposed to waiting to hear back from the payer via the 277 and getting that notification or request. The workflow just wasn't a normal one for many of them, as opposed to their own internal knowledge and history of what claims need the attachments up front. And then when we switched to going to more unsolicited, we immediately had like a 45% increase in provider adoption in like the first 3 months. So it was huge. Another big important lesson is you can increase the first time submission with the front end edits, as far as knowing upfront what data is going to be needed and which claims are going to need what attachments.
Great. Okay, Beth, from your perspective, you work closely with providers, so please share what your lessons learned are from working with the 275.
Thank you. I think it's less lessons learned, more observations, since I don't necessarily have solutions for them. And I work for a clearinghouse, Veradigm's clearinghouse, so I have some of the same perspectives that that Jamie with Japari does, but we also have visibility upstream into the financial system and how the provider gathers that. And what we see is it's still kind of onerous for the provider to retrieve that data and attach it to the file. If you think about just kind of the business operations piece of it, what the provider does is they have to go fetch the document from their electronic medical records, download it, put it somewhere temporarily, and then they have to name it a certain way, and they have to go into the claim and they have to say, hey, here's my attachment control number. Here's all the things that go with that claim. And they have to update the claim to match the attachment. And then they have to go and send that through the process, the electronic process defined by their partner, whether that's their EMR or their clearinghouse or whatever. And it's generally it goes through a separate, very many times it can kind of go through a separate process from the provider standpoint too. So I would say that we still have work to do to make that simpler on the provider. And for us, we are making strides toward that too, with AI and other tools to be able to pull those files from the data lake, similar to the automation that will be around electronic prior authorization, to kind of pull that information and populate those different fields. So that marriage between the two and linking them together is still pretty much manual. The second thing I'll say is, well, it's still way worth it. I mean, electronic transaction is a lot cheaper than mailing this stuff, so it's still worth it, but it's kind of clunky. And then I forgot my second point, but I don't think it was very important anyway. So I'll back.
Well, if you think of it, raise your hand. We'll come back. We are getting a little bit short on time, so I'll jump to our last question here, which is for the whole group, and I'll start with Chuck, since once again, I want to give you the opportunity to speak up as well. But WEDI will be looking at opportunities to assist the industry to implement this final rule. As co-chairs of the impacted sub-work groups, what resources do you think the industry will need over the next 2 years? So Chuck? And you may be on mute, Chuck. Okay, we'll jump to Stan.
Yes,
go ahead, Chuck.
I apologize. Yes, I think we're going to need to prepare promotional and guidance materials to be shared specifically with the provider community, who are going to be the source of these artifacts. One thing that we used during 5010 and ICD-10 migrations was to have presentations by our payer organizations at local and regional meetings and seasonal conferences, such as nursing association meetings, performing some targeted outreach to the people who are engaged in generation of the actual content that's going to be exchanged using the attachment transactions. We had good result with that, and it I think, strengthened the acceptance of the use of new standards at that time, and I think it's very applicable now. Thank you.
Thanks. Stanley, any insights here?
Yeah, the education is necessary, but I think the industry probably also needs guidance on where to go to ask the specific questions. I think we need to recognize that, I mean, CMS is the absolute authority on the regulatory questions. If you have a question about the regulation, the email address that they gave is certainly the right place to go. If you have a specific question about the standard, that's probably should be asked of either HL7 or X12, the right part of the standard. And then for the rest, a lot of times you'll have to, if you're a provider, you'll have to ask your health plan or ask your vendor. And WEDI, I think our attachments work group, as well as our claims work group, will be a great source to come to ask questions about the implementation process, really the business process around all of that. Some of the questions in the chat reflect some of those issues. So understanding the right place to go will be very helpful.
Thanks. Mary Lynn?
Sure, I agree with what Stanley said. Definitely education, guidance. If we could have a guidance paper that says, go here for these types of questions, go to this standard for this kind of question, that type thing, plus education. I think it's going to be really important for X12 and HL7 to provide detailed education to the industry. And that's probably going to be more helpful for vendors, clearinghouses, payers. As well as, some providers have their own IT staff that do the development as well. And then also, like Chuck said, we need to get the word out to the providers so they can push their vendors and clearinghouses that they're interested in doing this because of the savings. I know from our standpoint, from WebPoint Federal standpoint, we've done a lot of that with meeting with different, state provider organizations, things like that, trying to push them and say, hey, if you really want to do this and save money and, reap the value of these electronic transactions, you need to go to your clearinghouses, your billing services, your vendors, etc. So I think all of that's very important.
Thanks. Jamie, any additional comments?
Not really, just another opportunity is to join the attachment sub work group at WEDI. We'll be talking about this for quite some time and appreciate more insight and input from other members.
Thanks. And Beth, I'll give you the last word.
I think everybody said it best, and it's time to wrap it up.
All right. Well, thanks so much to everyone that's been on our panel. Thanks for the great discussion in the chat. And I'll turn it back over to Michael.
I'll take it, Pam. It's Rob here. Let me just add my thanks. Michael and Janelle, thank you for your presentation, but most importantly, thank you for your continued partnership with WEDI. To our panelists, fantastic discussion. Pam, a great moderating of the event. I'll say just a couple of quick things. I think CMS underestimated the potential savings associated with this final rule. I spoke with a medium-sized health plan earlier in the week who said they received on average 500,000 faxes a year. And even if some percentage of those are eliminated, you can see the tremendous opportunity for savings, not just in the faxes, but the manual handling of the information. So I think we're all very, very excited. This is one of those rules that once implemented is going to benefit all sides. It's going to improve data exchange between the provider and the health plan. So again, I think Jamie said it best. Get involved with these sub-work groups. Bring your questions. We've captured your questions from the chat, and we'll be getting those into the hands of the co-chairs. So get involved. Keep involved with WEDI. We've got our spring conference coming up in May, and we'll include some sessions on the attachments final rule there as well. So with that, I'll thank you all for joining. Thank you, Michael, for all your help with logistics. And with that, we look forward to seeing you at the next WEDI event. Thanks so much.